I like to cite a story I heard from a gentleman by the name of Lowell Cruz, who was a hospital administrator that retired probably about 5 or 6 years ago. And I saw him speak one time about a community event that he was hosting with his chief medical officer. And he looked around, and what he noticed were people who were slightly obese, who were eating barbecue and hot dogs and hamburgers. And he looked at his chief medical officer and he said, "What's going on with this?" And his chief medical officer said, "Well, what do you mean? What's your real question?" He said, "How do we stop this? How do we make a difference in somebody's life?" He said, "Well, first, it's about education. And second, it's about we as a hospital or health system need to quit sponsoring events and feeding them this, because it was a hospital-centered event for their community." So for them, it was about education. What really grabbed me about that story was that event took place in 1968, which is shocking. He recognized it early on. And a lot of hospitals and health systems are really trying to get outside those walls and start with education. And if you think about the care continuum, if you really want to impact health costs and health status, you've got to get someone before they get into a disease state. Disease management is great, health coaching is great, but it's almost a day late and a dollar short, to borrow that term. So intervening in someone's life before then is more important. So to your question, how do you do that? It's a sales strategy, it's a development strategy, it's an engagement strategy. It's about owning the data and owning the relationship in the communities that they serve. So data mining is absolutely essential to a successful consumer engagement strategy. The question is, where do you get the data? Claims data is great, patient data is great, but again, that comes back to the known. It comes back to the people that you've treated. For a hospital to be successful, they have to have data on people who are not even in their EHRs and EMRs today. And the way that has to be executed is literally, I hate to say like almost like a census worker, a door-by-door strategy. The easiest way to do it is to go to employers and having tighter relationships with employers, because they're the purchasers of the healthcare. You can aggregate people in populations around employers. Churches are great places to find people. Community centers are great places to find people. And the more and more we see hospitals getting into the payer game, if you will, and whether that's a Medicare Advantage plan or maybe even starting their own narrow network or direct contracting strategy, that's another place to get the data. But it starts with a health risk assessment or something akin to that, and creating relationships where one didn't exist previously. It's cheaper in the long run to get ahead of a disease state. So if you think about coronary artery disease, take that as an example. Education's a lot cheaper than a stent. A stent's going to be cheaper than a heart attack. A heart attack's going to be cheaper than a heart replacement, right? So the sooner you can get someone into a care continuum, and that starts with a primary care visit, or even, and I wish I had thought of this term because I think it's beautiful, but a pre-primary care relationship. That's a powerful thing. And health systems, the cutting edge health systems, are already doing this, and they're creating relationships. They're using their data to do that, and employers are the logical start. We've seen a lot of consolidation through the 90s, in the early 2000s in the payer landscape. I think it's interesting in that you're not seeing the rise of large national payers. What I'm seeing a lot of are smaller regional payers or HMO licenses being dusted off from the 90s. Several of our clients are doing that and getting back into the payer game, but those are community-based payers. That's a really intriguing strategy to me. I wouldn't place a bet on which way it's going to go. It's just interesting and to see the healthcare providers morphing into also having a risk relationship, but by the same token, you're seeing the larger national payers become providers of care. So a great example of that's the purchase of Monarch by United, or some of the regional ACOs that are being created between large health systems, provider groups, and large payers.